Good morning and welcome to this webinar. I'm Professor Nick Hardaker, Associate Dean for Research and Enterprise in the School of Human and Health Sciences at the University of Huddersfield and Professor of Nursing and Health Informatics. I'm really pleased to welcome you to this second Nursing Research Matters Learning from COVID-19 event. We are recording this event and we will be providing captioning with the recording. We're not captioning live. Our school, the School of Human and Health Sciences, is the largest at the University of Huddersfield. Perhaps unsurprisingly, we deliver education and we do research in a number of areas related particularly to health and social care. This obviously includes nursing, and we're very proud to be hosting this event, once again delivered in partnership with NHS England. We've responded to feedback from the first event, which was held in May this year, and hope to provide a very small but very relevant snapshot of research in nursing that's been carried out throughout the COVID pandemic. Since the very early stages of the pandemic, nurses have played a key role in its prevention and management. Perhaps less visibly, nurses have also been conducting important research that's resulting in new interventions and new ways to deliver care. Excuse me. Research that's helping us to better understand the experiences of patients and carers and the impact on the nursing workforce. Over the past year, Ruth May, the Chief Nursing Officer for England, and her team at NHS England have been collating research into a portfolio which demonstrates what we already know, that nursing research matters. This impressive portfolio is available via the webpage for this event. I think we as a profession should celebrate and take pride in our achievements. We'll see a small slice, just a small slice of this research today. Before I go on to introduce the speakers, I'm absolutely delighted to introduce Ruth May, the Chief Nursing Officer for England, who's taken time out to provide some opening remarks for this event. Ruth.
Thank you very much, and hello everybody and welcome to this event. I just wanted to say thank you. Thank you to you all for your extraordinary contribution during this global health emergency. It's been going on for many months now, and I am incredibly proud of each and every one of you, your teams and your colleagues for your contribution to this pandemic. Research has been and will continue to be important, but we've also seen this importance of research and the speed at which it has been done, it has been communicated, and the results of which have been implemented, I think will be something that we will look back in many years to come as something that we will feel huge pride in the way that we've taken research and implemented it to the benefit of our patients. Now, research has been a very important part of the vaccine programme, a very important part of the treatments, and about the models of care. And models of care, treatments have all changed during this pandemic because of the research being undertaken. Now, whether that is research nurses supporting research, being involved in research, and research nurses being the primary investigators, all of you and your contribution has made a massive difference to the way that we've been able to, between each of the waves, improve the care and therefore the outcomes of COVID-19 and indeed therefore the impact on patients. I want to thank colleagues in the research team at NHSE and I, thank Mark, Alison and Joe and colleagues, but also to colleagues there in Huddersfield for your partnership working with us. Today is about learning, it's about sharing, it's about celebrating, it's about networking. I wish you all a great day. I look forward to hearing about it, and thank you to everyone for your contribution to making research something to be very proud of the positive impact it has on patients during this global health emergency. Thank you for inviting me here this morning.
Thank you so much. Thank you for your encouragement, your support, your leadership, not just of research, but also on behalf of the nursing profession. So thank you. We're joined today also by 4 amazing speakers who are going to provide the content of the webinar and who are making a significant contribution to research in nursing. Louise Rose is Professor of Critical Care Nursing at King's College London and Honorary Professor in Critical Care at St Thomas's Hospital London. Today, Louise will be talking about virtual family visiting and communication with the intensive care team through the COVID-19 pandemic. Dr. Keith Cooper is Assistant Professor in Emergency and Critical Care at Warwick University and Critical Care Outreach Nurse at University Hospitals Birmingham. Keith will be talking about the impact of COVID-19 on the UK nursing and midwifery workforce. Dr. Lynn Kalman is Associate Professor in Nursing and Deputy Director of the Macmillan Survivorship Research Group at the University of Southampton. Lynn will be talking about living with treatable but not curable cancer during the COVID-19 pandemic. And finally, Catherine Evans has very recently been promoted to Professor at King's College London, congratulations, and is an honorary nurse consultant at Sussex Community NHS Foundation Trust. Catherine will be talking about the care home response to the need for palliative and end-of-life care during the pandemic. So interesting stuff. We won't be breaking between speakers, but we will be bringing them all back again after the talk to discuss issues raised by the research and broader discussions also. I'd encourage you to pose questions or make comments using the Q&A function at the bottom of your screen. There's no chat function associated with the webinar today. So if you do have questions, please post them in that Q&A section and we'll answer them towards the end. Before we begin, and perhaps a further kind of endorsement of the importance of nursing research and the nursing research agenda, I'm delighted now to introduce also Professor Mark Radford, who's Deputy Chief Nursing Officer for England and Chief Nurse at Health Education England, who'll provide some further context and perhaps set tone for the event. Mark will also join us for the panel discussion at the end. Over to you, Mark.
Thank you, and welcome, colleagues. It's great to join you today. I'd just like to echo Ruth's thoughts and say a huge thank you to all of you. I mean, this has been an unprecedented time, both for the kind of health of our nation, health and social care, but also our academic community. And I know that many of our academic staff from research and teaching backgrounds have supported NHS and social care in the actual pandemic response, alongside, of course, supporting many of your students, but also importantly, kind of the work you've been doing in terms of evidence and review during the pandemic. I personally have drawn upon the expertise of academics up and down the country on specific elements of approaches to the pandemic response, and I'm always very grateful for the wise advice and counsel that I get from the academic community. But this has also been a hugely challenging time in terms of moving forward your own research. And I know many of you will have paused your own programs, redirected your efforts to different questions, but also importantly, kind of focused on some of the here and now issues that we're faced with as a health service. But I'm kind of delighted that actually this has shone a light, as Ruth has mentioned, on the benefits of research. And it is really important to stress that, you know, nursing research has really evolved and developed. Even in my 30 years within nursing, I was inspired to be a researcher during my undergraduate programme, right through to the work I now do with a number of universities. It is really important to see how research is a fundamental part of the profession of nursing and what it can do, but also importantly, its role in providing the evidence for health and care beyond nursing, I think, is really important to stress. Much of what we do can and should have influence on a range of different approaches in terms of outcomes for health and care within the United Kingdom and beyond. But it's also important to highlight that there remains a number of challenges that we all recognise in terms of areas such as funding, access, posts, as well as also opportunities, I think, compared to some other professions. And that's why I'm delighted to be working with a number of colleagues who will be joining us today, but also importantly, Professors Cooper and Alison Richardson, who are helping develop the CNO strategy for research, because Ruth and I and many others have been working with government to really hammer home the benefits of not only nurses supporting and developing research, but also nurses leading research for the NHS and for the health and social care system. And we are going to be working actively with you as a community to develop and enhance the strategy to ensure that we can really show the realisable potential of nursing research for the future. I think we're building on a very strong base in terms of both expertise and also key capability across the United Kingdom. But I believe that there is so much more untapped opportunity there that I am really delighted to support Ruth and also the research community in developing a strategy that we believe that will make another leap forward in terms of the opportunities that this gives us for the profession, but also in terms of the outcomes that we want to see. So just to finally say a huge thank you for the opportunity to be part of today. I'm really looking forward to some fantastic talks, as well as also a great Q&A session a little bit later on. And just to say thank you for all your support, and I look forward to the rest of the day. So I think I hand back to Nicholas now.
Thank you so much, Mark. And I guess for the people attending today, to have the Chief Nursing Officer and the Deputy Chief Nursing Officer at the event is certainly worth a tweet or two. And we'll post the relevant hashtag in the chat. So moving on to the kind of core content of the webinar, I'll be joined. I'd like to welcome our first speaker to the virtual stage, Professor Louise Rose, and please, the floor's yours, Louise, and I'll see you all in a little while.
Thank you very much. So it gives me great pleasure to be presenting to you today on the research program that we have embedded in our virtual visiting solution. So I'm presenting on behalf of the Lifelines team, and we'll tell you a little bit about Lifelines and mostly about the research that we've built into the program. So taking everybody back, I know nobody wants to go back, but taking everybody back to March 2020, we were faced with a rapidly deteriorating and evolving situation where family visiting was being restricted across hospitals in the UK, and particularly in ICU that was seeing a massive influx of patients with COVID. We were suddenly faced with a situation where families were no longer allowed in. We had large volumes of patients and no good strategies in terms of being able to facilitate ongoing communication and a way of families to see their loved one in the ICU. So based on our understanding of what was going on, both in Italy and then coming into the UK, the Lifelines team together, which comprises of Dr. Joel Meyer, who is an ICU consultant at St Thomas's, and Joe Casey, who is our programs manager at KHP, and took us on as we needed a bit of help as we move forward with development, came up with a solution in conjunction with our colleagues in Canada that have the Touchaway platform that I'm showing to you now, to develop a solution that we initially thought was just going to be local and ended up being completely across the UK. So we came up with a secure video platform solution using the Touchaway platform, an exceptionally easy way for ICUs to use this secure solution on tablets that we generated £2 million in philanthropic funding to have tablets sent to ICUs across the UK with our virtual visiting solution on them. So you can see up here that this is what a tablet looks like in the ICU. It has a list of all the patient names that are in the ICU that are added onto the tablet. Then to add a family contact, we use an email contact, and the family members download the Touchaway platform on their own device at home. Our system is a one-way calling system because at the time, obviously, we couldn't have loads and loads of family members trying to video call into the ICU. So it's managed as an ICU calling the family system. And within the background, the organisation of the system on the e-platform can be built within individual organisations. So each hospital has its own organisation on the platform, and we can cohort into different ICUs. And the other benefit of our solution, our partnering with British Telecom and Google, was we sent these tablets out all ready to go in a jiffy bag. No 1 hour trying to download tablets and install programs. They were sent out with the virtual visiting solution locked onto them, ready to go. So after we did all of this work, we decided we needed to build in a research program about what we'd done. We'd successfully sent tablets out to 180 hospitals. And as of April this year, we've managed to facilitate over 100,000 virtual visits using our solution. So the research program that we built into our Lifelines work was we wanted to understand what the overall UK experience had been in terms of establishing communication and virtual visit for families in the ICU. Within the ICU teams, it became obvious in a lot of hospitals that the ICU clinical staff couldn't manage virtual visiting, and a lot of hospitals built family liaison teams that were often people that had never worked in ICU before. So we wanted to understand what their experiences were, either ICU or family liaison team members, in enabling communication and virtual visiting. Then we obviously wanted to understand the family member experience and look at, from their perspective, barriers and facilitators and recommendations for how we could do virtual visiting better. And we also understood, because our family members were going through a really intense emotional experience, we wanted to understand a little bit more about what was going on with them, both related to a virtual visit and overall. So to address these research questions, we've conducted 4 pieces of work. So we started off with that cross-sectional UK ICU survey, which I'm very happy to say is published and available in Annals ATS. We conducted our interview data set with qualitative interviews of clinicians, and that now is currently under review with BMJ Open. We conducted our qualitative interviews with family members, and I just submitted that paper to Intensive Care Medicine. And we launched quantitative measures of psychological well-being via our A Touch Away platform. So a rather cunning way to basically overcome the barriers in terms of recruiting family members to research, because they're no longer there in the ICU in front of us. So we got permission to send out recruitment flyers and embedded all of the questionnaires into our A Touch Away platform. So I'm very happy to be able to show you some results of this work as we've managed to progress it steadily over the time that we've been running Lifelines. So in terms of our national UK survey, we had 117 hospitals that respond. There's roughly 54% of the hospitals that we sent out the questionnaires to, and representing 180 ICUs. Remember that a lot of hospitals have more than one ICU. And when we asked about who was still being allowed to come into the hospital in terms of family members at the bedside in the ICU, the majority of the reasons for that was to facilitate an end-of-life visit. There were a few other reasons, but that was the majority of the reasons why family members were still coming into the ICU. Otherwise, they were totally prevented from coming into the ICU physically. In terms of the indications for virtual visiting, so who were ICUs giving virtual visits to, offering virtual visits to? So you can see in the table that the alert and oriented patients were commonly given visits, also patients at end of life. So family members may be coming in person, but also might get a virtual visit at end of life. And slightly controversially, only 59% of the hospitals that responded said that they were using this in mechanically ventilated patients. And there was some concern at the beginning of the pandemic with an establishment of virtual visiting, whether we should be enabling virtual visits for a patient that couldn't physically consent to them. However, us in Lifelines really had established this as a solution for family members of intubated and ventilated patients. Interestingly, we saw that virtual visiting was starting to have a clinical benefit. Hospitals were telling us they were using it during rehabilitation to help promote families' engagement and encouraging patients to be active in their rehabilitation sort of type activities. They were also using it as a way to potentially orient patients that were in ICU experiencing delirium. And so a range of interesting reasons to use virtual visiting was starting to be emerged. And this also was highlighted in the sort of qualitative section that we included in the survey, where we asked people to tell us about what they thought the benefits were. So obviously we were hoping that we would be reducing patient psychological stress by getting the family virtually present at the bedside. But the second most common thing that our respondents told us was virtual visiting also helped improve staff morale. ICU clinicians really like having the family members around. It helps us learn about our patients, particularly the sedated and ventilated ones. And so being able to see virtual visiting happening was really, really helpful to staff. And again, you can see that there's a number of clinical activities that were occurring with virtual visiting. In terms of barriers, one of the main barriers was still the digital divide of family members not having the technology to do virtual visiting. And of course, this survey was done just after the first wave of the pandemic. So another big barrier was staff not being able to have the time to do a virtual visit. So moving on to our qualitative data. So this interview data set with 36 participants who were either ICU trained or non-ICU trained family liaison team members, representing practices in 14 different hospitals. So I think this is the other advantage of our work and our Lifeline solution, is we weren't just doing single centre work, we had the ability to reach out to people in other centres. Within this interview data set, we established three main themes in terms of what virtual visiting was doing. One of them was restoring the family unit. And you can see here the quote that there's a key function in terms of connecting families, and families is not just humans. The whole morning she kept mouthing E, and the family were like, what's she saying? Because she had a trachea and so she couldn't really communicate. So I said, oh, she wants to see somebody beginning with an E. And they were like, oh, that will be Evie. And the next thing, a little dog comes running onto the screen and she's touching it going, Evie, Evie. So restoring the family unit doesn't necessarily mean bringing the family into the ICU. Virtual visiting can take the patient home to their own environment and their pets and so forth. Again, we saw in our interview data the theme of getting family involvement in patient care was an important facilitator of virtual visiting, both relieving psychological distress, but also again in that helping with rehabilitation and helping establish communication with non-verbal patients. And then there was the enabling of sense making as well. And you can see the quote there that's on the screen is that this physician was saying, you know, we're telling them all of this stuff. We keep telling them over the phone. We repeat the stuff all the time, but it's not until they really see it that it becomes real to the family members and really helps them make sense of what's going on and understand where their loved one is and their therapy in the ICU. So obviously there are different reactions, and we saw different reactions in our data set and with our interview participants. And so some people really, really struggled with virtual visiting, but I would put forward, having worked in intensive care for a very, very long time, that families also struggle with in-person visiting and what they can see and hear and smell. And so when you can see in this quote here, I spoke to the family and I said, look, he's going to be a bit puffy. You're not going to be able to recognize him as easily because he has tubes everywhere, lots of things you wouldn't want to see normally. And they were like, okay, and they saw him, and the mother gasped and started crying and walked away. And then the son was a bit shaken by it, and he said to me, okay, that's enough, thank you. And then that was the end of that. But conversely, other family members really seem to find good benefit from the virtual visit. And here, this other quote, sometimes it's a really sad situation, but it's gone well because although the patient or the relative seems so distressed, after the call, they'll say, I feel great now. And you're like, really? You've just been crying for like half an hour. You seem broken, but it's obviously released something for them. So that is our clinician interview set. So obviously we wanted to talk to the family members as well and get their perceptions. And so we embedded onto our virtual visiting platform the recruitment flyer, the consent form to ask them if they would like to participate in interviews. And so we got 41 family members representing 41 patients in 16 different NHS hospitals. So again, we're looking at different practices in a number of hospitals. 75%, 76% of these patients had COVID pneumonitis, and this interview set really was started happening over the second wave of COVID. And in terms of the severity of illness, so 20% of these participants, their relative had died in the ICU. And again, you can see that family members were recognizing that even though it's not the same as being in person, it's second best, it does give you something that really, really helped them manage and that they really appreciated. And what we did with this interview set is we really, as I said, wanted to learn from family members about how to do this better. So we identified in the data facilitators to the setup and to the conduct of the virtual visit. Preparation of the family was key. Negotiating a time with them and being flexible and having easy to use technology really helped with the setup. In terms of the conduct, actually having an ICU team member present, at least for a little bit of the call, was really, really appreciated. Enabling the family involvement care was something that they liked to have happen. And importantly, virtual visiting that was inclusive and accessible and flexible, so allowing a larger family group to visit and the flexibility of setting it up and giving the family members a sense of control was important. Barriers, on the other hand, were more restrictive virtual visiting practices and raising expectations and failing to meet them. Lack of pre-planning, lack of preparing the patient as well as the family member. And also the burden that this was putting on terms of some family members was seen as challenging. During the conduct, poor camera positioning was a problem, and patients are obviously often too weak to hold tablets. So we need to think about stands and way to make sure the camera is positioned and we don't just leave the camera there propped up on the bed. There were some issues with three-way connectivity, so forwarding the call to other family members. And one big thing was a lack of call closure. So not just turning off the video, but having a sort of closure process. I won't read the quote because I'm going through the time, but just to highlight in terms of what we know about the emotional response. So this data, as I said, we're just starting to be analysed. So all I can tell you is we recruited over 2,000 family members using this recruitment technique, representing patients in 36 hospitals using A Touch Away. And all I can show you is the basic demographic data that we collected. You can see total range of family members that participated. And some of these family members, and this was the first time they'd had a virtual visit, they weren't seeing their family member until over 2 weeks of that family member being in the ICU. So to conclude, what I think we've learned from the work that we've been doing is there are unanticipated benefits of virtual visiting, and these include the impact on staff morale and its role in facilitating family involvement in care. Virtual visiting can bring the patient home as well as bring the family into the ICU. We need to understand the digital divide and think about ways we can address this, and we can continue to learn from family about good practices, including inclusivity, flexibility, and accessibility of virtual visiting. And I think despite all the negative things that we've had to go through in terms of visiting restrictions, we have learned that there's potential opportunities that will enable us to give alternative visiting strategies to family members in the future that are unable to visit the ICU because they live in different cities, different countries, or just physically can't make it. So with that, I will finish and thank you for your attention.
Thank you. Thanks so much, Louise. As I mentioned in the introduction, we won't be pausing at this point for questions. We'll come back as a panel towards the end, and we'll move straight on to our second speaker. Just before we do, if you can, if you are tweeting, there's plenty to be tweeting about. Please do use the hashtag #OneProfessionalVoice so it can be picked up. Thank you. So yeah, moving on to our second speaker, I'm going to hand over now to Dr. Keith Cooper. Thank you, Keith.
So thank you very much for the introduction, and to the Chief Nursing Officer team, the NHS England and Huddersfield University for facilitating this exciting event today. It's my great pleasure to be able to introduce and present our study around the impact of COVID-19 on the UK nursing and midwifery workforce. I'm going to start at a similar place to Louise, and this is very much the kind of image that we were seeing in the first quarter of last year. This is an image that's come from Italy, where we can see a large number of high acuity patients receiving oxygen via various non-invasive devices. But we can also see the challenges of providing care to those patients, individuals wearing PPE that makes delivering that care extremely challenging. But I guess what we're not seeing is the wider impact of this. We've got to focus very much on the acute hospital. What we're not seeing is what's happening outside of that acute hospital and how the workforce, how it's planning out for the workforce in the community sector, the nursing home and residential homes, and all the other places where we provide care to patients. And it was really against this backdrop that the Royal College of Nursing Research Society committee, of which I'm a member, really put forward this idea of we need to understand what's going on and what the impact of this is on the UK nursing and midwifery workforce. And we joined together with a range of people from with some external collaborators and also us from universities and NHS trusts across the UK, and I've put their logos up there. I'm not going to name them individually, but it's been a huge team effort to bring this piece of work together. So in terms of what we did, we undertook a survey, and the aim of the survey really was to understand the impact of the COVID-19 pandemic on frontline nursing staff psychological health, potentially as a way to understand and facilitate recovery. But the first part of this was always to understand what was going on. So we undertook a 15 to 20 minute online survey at 3 time points. We envisaged that the first time point would happen before the peak, the second would happen during the peak, and then the third time point would be a recovery period, which we planned to be around 3 months after the first wave of COVID-19 in the UK. We made the survey available to all members of the UK nursing and midwifery workforce, student nurses, nursing associates, midwives, nurses, all of those really key individuals that contribute to our nursing and midwifery care. We also aligned it with a Royal College of Emergency Medicine survey that had also been planned at the same time, and I'll come back to that slightly in a bit. In terms of how the survey was designed, there were 6 broad domains to the survey, which are listed there. And we tweaked some of the questions at each time point, really to reflect our changing understanding of the pandemic's impact. In terms of what we were particularly interested in, we used varying scales and validated tools to understand what was going on, and we measured those at different time points. Some of those were only measured at the final time point, really to reflect the fact that the nature of that particular outcome. Our analysis, we treated each survey time point as an independent sample. There are reasons for that. It's difficult to go into them today, but there are various reasons for that. We did impute data. We had data missingness, which is inevitably unsurprising when you're presenting people with a 15 to 20 minute survey in a time of where it's incredibly challenging, and they're undertaking the survey, you know, on their days off and trying to fit it in amongst everything else that they're trying to do. We looked at the instance of each outcome at each time point, and then we used the multivariable logistic regression model to look for associations between some of our variables and a score on the impact event scale revised that related to a probable PTSD, acknowledging that it's not a clinical diagnosis. One of the things that we were incredibly keen to do was at each survey time point to release a snapshot of our results. The reason for doing this is we really wanted this, if it possibly could, to inform the developing trajectory of what was happening. So if there were key findings, that we could act on those quickly and address those. So one of the things we did was at each of our first 2 surveys, we released a press release and released results via social media to really help people to understand what we'd found. And we were delighted that we did see we saw wide interest in our results. So as well as the professional nursing press, they were picked up by The Guardian, BBC and various other media outlets. And that was really important, we felt, in terms of trying to influence things as they happened. In the introductory comments, there was a comment around the fact that many of these pieces of work were set up extremely rapidly, and this was no exception. We conceived the idea on the 21st of March. By day 5, we'd submitted our ethics application. The ethics committee were incredibly receptive, incredibly helpful, and were able to give us approval the day afterwards. And then just 6 days later, we were able to release our first survey. So we had a 12-day period from developing the idea, establishing the team, to disseminating our first survey. I said at the beginning around what our plan had been in terms of our survey time points. It didn't quite work out as we had planned. What we actually saw was our first time point started, and you can see here where we've plotted our survey time points against the number of hospitalised COVID-19 patients across the UK. And what we can see is that time point 1 trajects that period from a rapid escalation in cases to reaching the peak. Time point 2, which went out only 2 weeks after time point 1, was really the time point where we'd started to see a de-escalation in cases. Of course, that's not to say that the burden on the health sector was over. Even in patients that have been discharged from hospital, there are obviously ongoing health needs that affect care beyond the hospital sector. I think when we get to time point 3, we can see very clearly that we'd reached a nadir of cases. Cases were rapidly de-escalating, and we'd reached a point where it was a relatively stable situation. And that was around August of last year. Across our 3 survey time points, we had 7,840 responses. And you can see there the breakdown across the time point 1, time point 2, and time point 3. I'm going to present to you now some of the findings of our survey and try and put them into some context. In terms of gender, 91.6% of people reported themselves as female. Ethnicity, we didn't have here the diversity that we wanted. We made much effort to try and reach out to many different groups. We tried to use social media. We tried to use various different angles to promote and collect this important data from all groups within the UK nursing midwifery workforce. Unfortunately, we didn't succeed as well as we'd hoped, and 91% of our respondents were white, with fewer than 10% being from other ethnic backgrounds. 77% of our respondents were employed by the NHS, and the majority of our, almost 50% of our respondents had some sort of care and responsibility at home, whether that was a sole carer or whether that was having a joint responsibility with someone else, whether that was for a child or a parent or other individual. In terms of our characteristics in terms of category, the majority of our respondents came from staff nurse, senior staff nurse or charge nurse categories, so a sort of band 5 to band 7 on the Agenda for Change scale. Again, we were underrepresented in terms of our respondents from healthcare assistants and nursing associates and student nurses and other individuals that might not be banded. Again, we tried hard, but unfortunately, we didn't get the coverage that we would have wanted. So I'm going to talk here about some of the experiences that we found during the pandemic. What you can see here is that the blue bar represents time point 1, the red bar represents time point 2, and the green bar represents time point 3. What we can see here is that when we look at PPE, we can see that fewer than 40% of people reported the correct PPE was always available at the first time point. And whilst it's fantastic to see a rapid uptake over the even just to time point 2, we're still seeing even at time point 3 more than 30% of people reporting they didn't always have the correct PPE available. There was a widespread lack of confidence in the infection prevention and control training that people received. Inevitably, this is partly a function of the fact that this is a novel virus, and there was a huge amount of uncertainty as to exactly some of the processes that should be adopted. But it's important that even at our third time point, only just over half of people had confidence in their training. Again, undoubtedly linked to the fact that it's a novel virus, which made case presentations very difficult to do anything we'd ever seen before. People frequently reported they didn't feel prepared to care for patients. And on the final bars there, we can see the proportion of people reporting that they were redeployed with no or inadequate training. And what we can see there is in excess of 60% of people at all time points reporting that they didn't feel that they had received adequate training for that redeployment. In terms of our outcomes, if we look at the impact event scale revised, we can see here across our 3 time points, there was a decrease in the number of people meeting the criteria for either probable PTSD or PTSD of a clinical concern. And whilst it's important that declined over time, it's incredibly important that even at time point 3, we're seeing important proportions of people that are still reporting adverse psychological wellbeing outcomes. I mentioned it earlier on about a study being undertaken by the Royal College of Emergency Medicine, and I've plotted here that their findings of around 10% were reporting equivalent symptoms. This is not to say that to diminish in any way the experiences of other professionals. It's simply to highlight the fact that across different professionals, we had very different experiences of what was happening. In terms of other outcome measures, I'm going to summarise these relatively quickly, but for depression, we saw an important proportion at all 3 time points, although that didn't change over time. For anxiety and stress, again, we saw important proportions reporting symptoms, although it did decline over time. Perhaps the most important part of this slide, though, is that last bit where we can see that people reporting they were very or somewhat unsatisfied with their job increased over the 3 time points. So by the time point 3, we had almost 25% of people reporting they were very or somewhat unsatisfied with their job. The reasons for that are unclear, but it is an important potential impact on our workforce. I mentioned that we did some modelling to identify the association between various factors and an impact of event scale score that reflects probable PTSD. We categorised variables as either personal factors, so linked to your sort of home life, or sort of general factors, and factors that were specifically linked to the workplace. I don't have time, unfortunately, to go into all the different associations that we found. I think one of the key things really is to highlight that we found associations between both personal and workplace factors across all 3 time points, and that these changed across the trajectory of the COVID pandemic. So I'd like to conclude by highlighting that the COVID-19 pandemic has had an important impact on the lives and psychological well-being of the UK nursing midwifery workforces. I think it's important to remember our survey was limited to the first wave of the pandemic. The effects of the pandemic are certainly not over, and since then we've obviously had a second and a third wave. We do need to better understand the lived experiences of those working throughout the pandemic, and there's important work being led by Jill Mabon at the University of Surrey, using a sample of participants that responded to this survey, where we're undertaking some in-depth semi-structured interviews to really understand their experiences. And I guess the key point here is we need to understand what works to optimize psychological well-being, and we really do need a high level commitment to ensure that happens. I'd like to finish just by thanking the many participants that kindly responded to our survey in the most challenging of times for them. We are incredibly grateful. The Burdett Trust for Nursing provided some funding towards the work that we did, and also to remind everyone this was very much a team effort from a large number of organisations across the UK, and to thank those colleagues for their support in bringing this work to a conclusion. So with that, I'd like to thank everyone for their attention. I'll hand back to Nick for the next speaker.
Thanks so much, Keith. Food for thought, certainly. Just to answer a quick question, yes, this is being recorded, and it's being captioned as well to make it accessible to a broader audience, so it will be available after the event. Moving straight on, in the interest of time, I'm going to hand over now straight away to Dr. Lynn Kalman to deliver her presentation. Lynn, over to you.
Thank you very much. Great. So thank you very much for the invitation and the opportunity to speak about the ENABLE study, which focuses on people who are living with treatable but not curable cancer during the pandemic. This is a really collaborative and multidisciplinary piece of work. And I'd like to thank our collaborators. The work is led by the University of Southampton with the Christie Hospital, NHS Trust and University Hospital Southampton. The work's funded by Macmillan Cancer Support, and it's funded by a 3-year project. So this was a project that had already started before the pandemic. And in fact, we repurposed the work to make sure that we were capturing the experience of people during the pandemic. So I'm going to talk a bit about that. To give you just a very brief background, the research focuses, as I say, on people who are living with treatable but not curable cancer. And these are people who are living with advanced cancer. And this type of cancer can very rarely be cured, but can for some people be treated to help manage symptoms or slow the progression of disease and indeed extend people's lives. And this group have only recently been identified and described as a subgroup of the nearly 3 million people who are living with and beyond cancer in the UK. And this group is emerging because of improvements in treatment. So targeted and immunotherapies are meaning that people are living for much longer with disease that is incurable, and sometimes for years. And it's been estimated that around 130,000 people in the UK living with treatable but incurable cancers. And we know from some very preliminary evidence from Macmillan that they are living with complex needs. There are many decisions that these people have to face and live with great uncertainty about their treatment pathways, and that their needs are likely to be different from other cancer groups. And the NHS long-term plan for cancer states that people will have access to personalised care and support planning, but we need to understand people's needs in order to deliver this ambition. So the ENABLE study was set up in 2 different phases, and I'm not going to talk about the whole research design. We have published our protocol in the European Journal of Cancer Care. So if you want some more detail, then please go there. And I'm really only going to focus on the longitudinal interview study. And that was the part that we repurposed for the COVID work. So we had planned to recruit and interview 30 patients and up to 30 carers 3 times over the course of 12 months. And these longitudinal interviews, the participants were recruited from 2 cancer centres, one in Southampton and one in Manchester. And these have diverse populations and care settings. It was a purposeful sample with reference to age, gender and cancer type. And the carers involved were nominated by patients. And we asked patients who they felt they got most support from, and they were recruited in that way. with our interviews, carers and patients were interviewed separately. So in terms of the timeline, recruitment started in July 2019, obviously before the pandemic started, and we managed to recruit 30 patients and 22 carers to the study. So by February 2020, everybody had consented to the study and had taken part in one interview face-to-face. So then, of course, we got to March 2020, where we had the first lockdown. And of course, at this point, researchers were asked to pause any non-critical research. And we really, like many researchers, had to think very hard about what we were going to do with this longitudinal piece of work. So we went to our patient and public involvement group, who were really excellent at talking through the issues with us and had some very clear recommendations about what they felt that we should do now. So we went back to our participants and said, we'd really like to continue the study. Would you be happy to do the interviews by phone rather than face-to-face? And could we refocus the study now on your experience during this first lockdown? And we were really pleased that everybody who had consented actually said yes, that they would like to continue with the study. So we then agreed that with our funder, went to REC and went through all the governance processes to let us repurpose this work. That was all done very quickly. And so we were delighted to be able to carry on with the research at such a challenging time. So the focus of the research question was around the impact of COVID-19 on people living with cancer that was treatable but not curable. So we undertook telephone interviews between March and June 2020. This was, of course, an opportunistic subsample of people who'd already participated in the main study. And we used a thematic rapid analysis to make sure that we delivered timely results with good methodological rigor as well. And throughout the process, we consulted with a group of clinicians and our patient and public involvement group, our user reference panel, to make sure that we were really on top of what the stakeholders were thinking at the time. So within the subgroup, we had 21 patients and 14 carers. They were diagnosed with a range of cancers. Most were still receiving active treatment or were between treatments. And people had quite a variability of their health status. So some patients were really very well, and other patients had a lot of needs physically. And all of our participants had received a letter advising them to shield. So I'm going to talk through the initially our key findings, and I'm going to focus first on psychological, social and emotional impacts. So for the participants, their ability to maintain independence and normality had been greatly impeded by the pandemic. And one of the advantages of having the longitudinal data was that the first interview was prior to the pandemic. So we had been beginning to see these things coming out very strongly in our data anyway. And it was very clear that the things that were really important to people had been very much impeded by the lockdown. Opportunities to do things that were really important to people were lost. And this was particularly important because clearly these patients have a limited time left to live. And patients and carers talked about experiencing much more uncertainty and anxiety. And we can see here a quote from Cedric, one of the patients, and he talked very powerfully about feeling like he was wasting the time that he had left, a real feeling of frustration that he wasn't able to do the things he wanted to do. He had lots of plans, seeing the grandchildren, playing golf. And he asks at the end there, will I ever be able to do these things again with this COVID? Who knows? Our participants also talked about no longer being able to participate in the social activities that were important to them to help them maintain a sense of purpose and normality. So many participants were part of voluntary groups, clubs, classes, things like outdoor exercise to give them a real sense of purpose in their lives. And that was obviously stopped during the first lockdown. And also being unable to see people who are loved ones had a significant impact on people's emotional well-being. But we did see in the data very clearly that there was a greater use of technology for people to stay in contact and stay connected. And again, we can see an illustrative quote here from Fred, and he talks about it being very, very annoying that he can't see his family. He misses seeing his grandchildren, but his daughter has organised a virtual quiz, and that has given them an opportunity to stay in touch. In our data, we also highlighted that the impact on people's healthcare. And of course, these patients were all diagnosed before the pandemic, so had existing relationships with their healthcare teams. And so patients continue to feel well supported by the healthcare teams, and were also very supportive of phone consultations. And within this sample, people tended to have a phone consultation rather than other types of virtual consultations. But again, in the data, we could clearly see that there were concerns about impact of the changes of aspects of their care and treatment. And we can see this illustrated by Sam. And he talks about that he trusts the professionals, but I would still like to perhaps sit down with my doctor. Next time, I'll probably ask him long-term, are the changes to my treatment detrimental to my maintenance? I trust the NHS, and I totally see the logic behind not being able to come into the hospital. But clearly in the data, we could see that people had concerns about whether these changes were going to make a difference to their long-term health and well-being. So all of the participants were shielding, and in the last one of these webinars, there was a great talk from Anne Caress talking about shielding populations. And the patients and carers in the study did have concerns about shielding. They'd all received a letter. They found it very difficult to follow and manage the recommendations that came around shielding in the first instance. But we particularly saw in the data the worry and risk that carers themselves felt that they posed to patients' health when engaging in some of the supportive activities that they had to do. And we can see here from Daniel, who talks about not wanting to be responsible for passing on a germ to my dad that could finish him off. I'm paranoid. I don't want to because my dad can't go out and do these things. So there was real concern about the shielding process and how that worked, and particularly, as I say, carers' impact on patients. But we also saw concerns about the lifting of shielding. And of course, we're still in quite a complex and difficult situation and a lot of uncertainty. And Cedric here talks about feeling frightened. You know, it's frightening, isn't it? I'm in a vulnerable situation, there's no doubt about that. And I'm frightened that when they lift the lockdown, if it's lifted, it's going to make no difference to me. I'll still have to be ultra careful. So lots of ongoing concern. Our participants talked about adjusting to a new normal. And of course, this group of people have already had to adjust to a new normal after their cancer diagnosis. And they did use some of the adjustments that they'd already made to help support them during the pandemic. So for example, many of our participants had to be socially isolated to some extent because being immunosuppressed during their treatment. But they also developed strategies such as maintaining a routine and trying to achieve tasks at home in order to get them through and adjust to the normal. And Karen here talks about it's just a case of getting everybody safely through this pandemic. I suppose it's adapting to how we're going to go back to something approaching normality. I think a really important and interesting point that came out of the data was a sense of shared experience, and the fact that the context of COVID-19 actually supported the process of adjustment for some participants. And one of our participants here says, it's been a good thing for me, this coronavirus, because it's given me time to get my head sorted. It's helped me. Yes, it's a stupid thing again, but I know damn well it's not just me in this boat, it's the whole country and most of the world, isn't it? So in a way, some of the responsibility and blame is off me. And again, one of our carers talks about feeling so trapped since her husband became ill. The fact that we all went into lockdown made me feel better. It just made me feel like everybody else. I'm not just watching everybody else go on holiday. And I know it's a totally selfish thing to say, but that's how I feel. It's just been like this for me for a long time, really. So actually having that resonance with the rest of the country was really helpful for some of the participants. I think an important finding of the research, and I think one of the reasons we wanted to include carers was because there was a clear impact on carers' health and well-being during lockdown. And so some carers were definitely experiencing a higher burden related to social, practical and emotional support, and respite from formal and both informal support was limited. So for example, many of our participants went to support groups at the hospice or other types of supportive activity, and those all stopped. But I think importantly was also the informal sources of support stopped. So often a son or daughter might come round at the weekend to give everybody a break for a couple of hours. And of course, that all stopped as well. So it wasn't just the formal, but the informal sources of support that were very important. And we have Mary here talking about just feeling really lonely and isolated. She speaks to people on the phone, but it's not the same as actually seeing people. So based on these findings, we worked with a group of healthcare professionals and our user reference group to think about developing some considerations for practice. And of course, within that, we really had to acknowledge the context that was there for healthcare professionals on the front line, and knowing that they've been having to cope and adapt to a really challenging healthcare context due to the pandemic, and that things have changed and patient safety has been a priority.
Just one more minute, please, Lynn.
Yeah, no problem at all. So we developed our report, and which highlighted some resources, and hopefully the report will be in your the chat now, and you can have a look at that. 3 things just to highlight was making sure that we do support carers, even now they're not able to come into the clinical centres, how we support people who don't have access to online, and also making sure that healthcare professionals are able to prepare for difficult conversations with patients about the impact of treatment. So I think this provides rich data that is going to help us address issues in the delivery of cancer care now and in the future. We've been working really hard with our public policy at Southampton Group to implement our impact strategy, working with Macmillan, with the NHS cancer programmes, making sure that we're disseminated our policy briefings to government departments, and working with cancer alliances. And if you want to know more, our paper has just been accepted and is in press at Palliative Medicine. That will be open access, and our report can be found at our website. So thank you very much.
Thank you so much. Sorry to push things. I'm keen that we do have time at the end for some questions. So I'm going to move straight on now to Catherine Evans to deliver the final presentation of the webinar. Catherine, over to you.
Thank you. Are you able to see my screen?
Yes, perfect.
I've just got a problem with my sharing. Hold on, I'm just going to do that again.
Yes, we can see that.
Okay. Thank you. So thank you very much for inviting me for this presentation. So I'm going to continue the theme of palliative and end-of-life care, but I'm going to change our focus now more to the community and think specifically about care homes. I'm going to present some research called the CovPal Care Home Study, which was looking at how care homes provided palliative and end-of-life care during the pandemic. So first of all, what's important for us to remember that during the pandemic, we've seen a huge shift in place of death from hospital into the community. And this graph from some work from Sean O'Donnell from University of Hull illustrates this very nicely. So what you can see is this yellow line here, which is care homes. So in the first wave, we saw a 134% increase in people dying in care homes during COVID. And also to remember that many more will have experienced distressing symptoms and concerns. But of course, coupled with the increasing demand in care homes was also the increasing demand for people with progressive conditions, with COVID, who were dying at home. And this is this blue line here on the graph. So for people at home, we saw a 41% increase in deaths for people at home, with that being sustained across the pandemic. So this is very much giving a sense of the huge demand that was placed on community services during the pandemic. And when we think about that huge demand, I think it's really important just to take a moment to reflect on what that's been like for the practitioners. So this is a quote from one of our participants in the study, who's a lead nurse in a nursing home. And she wrote down her reflections on what it was like providing care during that first wave. I'll just give you a moment just to read her quote. So you can see her quote is very, very powerful, describing her care home service as in crisis. And also importantly, that delivering care within a care home is very much a system approach. It very much relies on the integration between social care and our primary and healthcare and primary and community service, particularly GPs, pharmacists, community nurses, and paramedics. So what were we trying to do? So we wanted to examine how did care homes respond to this huge increase in demand for palliative care? And the reason for asking that question was very much about, well, how can we learn from what happened in the pandemic? What were the innovations that occurred that we would want to ensure continued during the pandemic now, as well as how can it inform how we deliver high quality palliative care after the pandemic? So we were interested in what worked, what were the facilitators and what were the challenges? And also probably most importantly was what has been the impact of all of this on the staff. So how has this impacted on the care home staff? So the way we approached this study was that we had two main work packages. So the first one that you can see in the diagram at the bottom, package 1, where we used a UK-wide online survey to all registered care homes. It used a mix of both structured and open free text questions that took about 20 minutes for people to complete. We were asking about what was the impact of COVID-19 on staff morale, how did they provide palliative and end-of-life care, what was their access like to external services, what was the support of staff, how did they communicate with family, who you will all remember experienced restricted visiting during this time. Used qualitative interviews in work package 2 to do a deeper dive to understand the experiences of those care homes care. And this gave us then an opportunity to explore more about their experiences, about particularly the impact on the workforce, particularly about how they managed restricted visiting at the end of life, and particularly about how they were able to access external services to provide the care that they wanted to deliver. And then what you can see on either side of this is, just as other presenters have talked about, is the importance of patient and public involvement in the research. So working alongside us is a group of family carers, all of whom have had family members or have family members who are residing in a care home. Also, very importantly for us over on the right-hand side is our care home expert panel. So this is a group of care home leaders, so individuals who are working in care homes as managers, as directors, as lead nurses, as matrons, that help us to ensure we ask the right questions. They're helping us now in interpreting our findings. So one of the challenges of conducting research in care homes across the UK is, how do you obtain that reach? So we worked with 4 national networks to help us achieve that. So the 2 at the top are funded by the National Institute of Health Research, and then the 2 at the bottom are 2 charities. So the Queen's Nursing Institute, that has a care home nurses network with over 800 members, as well as the Association of Directors of Adult Social Care. And what we asked our networks to do was to disseminate the survey to all of their members, following that up with reminders, and us coupling that with a promotion on social media and through their respective e-news. We then, for the qualitative interviews, identified survey respondents, and we were particularly looking for interviewees that could provide the representation of care homes that provided nursing care, and also residential homes that don't have on-site nursing, and also the wide variation in size of care homes, as well as across the regions in the country. So I'm going to present some of the preliminary findings from our work. So our survey is still open. It would be great, I'll pop in the chat for people who are working in care homes to be able to tell us about their experiences. So what we've found so far from our respondents is that about 2/3 of them had experienced COVID outbreaks. So really helpful for us to understand the impact of COVID and remembering that not all care homes experienced outbreaks during the pandemic. You can see on the table that most of the care homes were coming from regions where there were high cases of COVID, which is what we would expect. And from this information here about what those care homes look like, you can see that they are reasonably representative of the national picture, in that most of them are medium-sized and most of them are coming from our residential homes or are providing a mix of both residential and nursing. The pie chart on the right just illustrates our reach across the regions in England and also to the devolved nations of Scotland and Wales and Northern Ireland. So in terms of presenting the findings, I'm just going to give you a flavour of two key areas, and these are two key areas for policy. So those areas are around staffing, and then I'm going to look at family visiting at the end of life. So what this slide is illustrating is the table is the responses to our structured questions. And then also to give a bit more richness in understanding that data, I've included some of the quotes from the participants in their responses to the open questions. And what you can see on here is that the care home staff were experiencing layer upon layer upon layer of challenges. So you can see that most of them experienced staffing shortages. Their staff were having to rapidly increase their levels of responsibility. So, for example, giving injectable medication at the end of life in residential care homes, verifying death. So things that staff had not previously been trained to do, and being asked to do that with training from online guidance, e-learning, reading documents. So unsurprisingly, most of them reported, or a third of them reported, that they had fluctuating quality in their provision of palliative care, but some important signals that they were able to access the palliative care advice as and when they needed it. But a third of them also reported challenges in accessing other external services. And a common thread within this is about accessing services out of hours. So as the quotes illustrates, this was something that was described as outrageously difficult in trying to get help out of hours, so a weekend and on the evening. And so what this is helping us to do is that we're now beginning to identify some of the themes around staffing. So one of the main things is around that this is very much an agile and skilled workforce. So one of the key findings is that, of course, our care home staff are skilled, knowledgeable experts in palliative care. And what's very important in the policy recommendations is recognising and communicating their expertise. But what needs to happen is for us to be removing the many layers of challenges that they experience that prevents them from delivering the care in the way that they would want to. And very much the need for care homes to be seen as equal partners with primary and community care. So things like having an accessible hotline to access pharmacists, to access GPs, to access end-of-life advice, and not being at the mercy of 111, as this quote over here quite nicely illustrates. And what you can also see from this bottom quote is that when they had access to the external services, that prompt, skilled access very much enabled them to deliver that care, but that was not always in place. And then for the next snapshot of results is just to think about the family visiting at the end of life. And this is very much a theme that's merging around trying to replace that human contact. So you remember that during the pandemic, particularly in the first wave, that families were not able to visit, and visiting was only really allowed at the end of life. So again, what we've done, I've presented this finding just for you to see the difference between care homes that had experienced COVID outbreaks and those that hadn't. And what you can see that most care homes allowed visiting at the end of life. What end of life meant was very broadly interpreted. But you can see that in trying to deliver care at the end of life was very challenging. So particularly in communicating with the family who were not present, the challenges in assessing and managing people near end of life, and in recognizing when somebody might be dying. And this was particularly challenging with residents with COVID, because as we all know of the rapid deterioration that was often associated with people who died from COVID. And again, you can see from this quote as to how challenging this was for the care staff in not having the family present, that they were very used to relatives being with a person when they were dying, that they were spending time with them, and that was not possible. So again, the themes that are emerging from this is about upholding compassion and trying to balance the risk between visiting near end of life and preventing and controlling infection. So again, one of the main themes coming out is again in recognizing staff expertise and confidence to assess each individual resident and to be making decisions about when an end of life care visit should take place. And as the quote illustrates over here, there is no right fixed time for when when somebody should visit at the end of life. It was very often very difficult to know when a person was in their last weeks or last days of life. And again, from the quote, you can see the passion from this workforce about upholding humanity and compassion, and about how to support family members during very, very unique circumstances, and their frustration and distress about not being able to spend time with family members when they were visiting somebody who was dying because, again, of the infection control and prevention measures. And I think what's very powerful is this bottom quote, which says, due to staff shortages, we were not able to vigil as they would normally. So this absolute despair, really, for care home staff in their experiences of not being able to vigil, a very powerful word of not being able to sit with the person as they were dying. So finally, this is the final slide, which is our themes and recommendations for policymakers. So as you can see from some of the findings that I've presented, key is around trusting the expertise of care home practitioners to deliver high quality palliative and end of life care. That they very much need the autonomy to be able to assess and agree for family to visit towards the end of life. But for them to be able to achieve and to work at this level very much requires prompt access to skilled external health resources, particularly at increasing complexity of residents' needs. And then finally, in terms of the themes, is the importance of providing accessible guidance. So as one of those quotes showed, that at the beginning there was very little guidance, but in the second wave and still now, care homes have been deluged with information. But often that information has not been written for the care home context. It's often has a lot of brevity to it. And there is a need for information to can be conveyed succinctly and also with appreciation of the context of the varying resources in a care home for that guidance to be adapted. So particularly the difference between a care home that has on-site nursing and residential care homes that are not required to have that for their registration. So some of the key recommendations that we are now pursuing within the data to make to policymakers is very much that to maximise integrated working between health and social care requires care homes to be seen as equal partners with primary and community care services. There is very much a need for skilled end-of-life care hotlines for care homes to be able to access expert support, particularly out of hours, at weekends, at night. And finally, as I said, for guidance to be written in a way that is accessible for care homes, that they can actually apply it in their context. And then finally, I would just like to acknowledge our very extensive research team. This is like all of the other studies that have been presented. It's very much a collaborative research project. I particularly like to acknowledge Catherine Sleeman, who co-leads the study with me, our steering group members, our PPI study reference panel, and our care home expert panel. And finally, just to say thank you very much for listening. I've just put on the screen here the QR code for our survey. As I said, if you're working in a care home, we really welcome hearing more about your experiences. please do keep in touch by email or on Twitter. And there's more information about the study at the project website. Thank you very much for listening.
Thank you. Thanks so much, Catherine. I'm going to invite now the speakers and Mark Bradford of NHS England and Health Education England to come back to the stage. And while they're tripping their way up the steps to the stage, I just wanted to kind of celebrate, I suppose, and congratulate the speakers on their presentations, on the work that they've done, and delightful to see not only the kind of the observations that are being made, but the kind of tangible recommendations that are coming out of that really very high quality work and exceptional presentations. So I just wanted to, in terms of the questions, your questions in the question and answer in the Q&A box are really important questions. Many of them are very specific. We don't have time to answer all of the questions in addition to those questions that were sent in as part of the registration process. What I'd recommend is for the specific questions about studies, please contact the PIs, contact the speakers directly about questions to those, answers to those. I'm sure they'd be very happy to help out there. I've got two, because of the limits on time, I've got two really quite big questions that the last 10 minutes isn't enough time to cover each or both of them, either of them. But I would like to talk about a couple of things. One is about engaging in research or growing nursing research. We've seen how good it is, we've seen how important it is, we've seen what difference it makes. So that's one of the questions. The second question is about diversity, which was pointed out very early into the presentation, visibly the lack of racial diversity across this panel. It extends beyond nursing, of course, and nursing research into academia as well. So I wondered if we could start, and I'd like to hear both from Mark from a strategy and policy level, perhaps first, and then hear from the speakers at the kind of more the grassroots level. So Mark, I wonder if you could just talk for a few minutes about what's happening, what we can do to kind of grow nursing research, to elevate its status, perhaps get more people engaged in research.
Yeah, thanks, Vickers, and thanks, Victor, for raising that question. I think it's fundamental that we face up to some of the structural issues that we have, both in terms of the NHS society and also in terms of the research community, to our Black and minority ethnic colleagues. The simple fact is that there is a surfeit of data that highlights that Black and minority ethnic colleagues have worse employment experiences working in the NHS. They have less ability to progress in their careers, and that is replicated within our university sector. And I think it's really, really important recognising that, I was looking at the data, between 30 to 35% of our undergraduate nursing and midwifery colleagues coming through our programmes are from a Black and minority ethnic background. So, there are serious structural issues within both our processes and also our approaches that need to be addressed, both at university level and also from a health and social care perspective that widens out the opportunities of fabulous and brilliant colleagues to come through, where actually it's fundamentally 2 or 3 times harder for somebody from a Black and minority ethnic background compared to their white colleagues. So I think the first thing to do is recognising and face up to it. Obviously, from the strategy perspective, Ruth has been working to develop lots of areas of practice around widening out opportunities, particularly in terms of both leadership career progression within nursing for colleagues from Black and minority background, and the same for research. And it's a fundamental part of the research strategy we're developing to deal and tackle with that, which is about widening out opportunities, improving opportunities for growth, development, mentorship, etc. Something I do in my own personal practice in terms of supporting early years career researchers from Black and minority backgrounds is really fundamentally important. And I say this to kind of white colleagues all the time, which is that, yes, we are in these positions and, we have worked hard to get there. But Black and minority colleagues and female colleagues and other protected characteristics often have to work 2 or 3 times harder to get to the same position. So it's fundamentally important that actually we use our approach to lift up others, call out some of these issues and challenges. And I'd just like to kind of finalise and finish on say, actually, we've got some scholars who are doing very much this and calling out some of these practices and actively working in this space. Professor Calvin Morley is a friend and colleague who is doing a lot of work around looking at undergraduate curriculums, decolonisation, and approaches to kind of raising the bar around support for Black and minority colleagues coming through both academia and also through from student practice. And colleagues, as well as also Professor Laura Sarant, who've been doing work for many decades in challenging this. So I think there is a great deal to do, and I welcome Victor's question and challenge to us about how do we address that, both in terms of strategy, but the most important thing is action and delivery in individual units and practices out there, so we're better able to reflect the diversity of our nursing community and also the community that we deliver research and care for.
Thank you so much. And I can I turn to the speakers actually, and thinking about kind of expanding research, drawing on your own experience and thinking about how can people engage across the widest nursing community, thinking about what steps you took, what advice would you give to people who are embarking on a research career. So could I ask perhaps Lynn to step in here and talk from your own experience? How can people kind of, what would your advice be to people who are starting this journey?
Yeah, I mean, I certainly think in Southampton we're starting as early as we can. We have a research-informed curriculum. We have a master's student who actually is working alongside us and doing some secondary data analysis for her dissertation using the ENABLE data. So it's about making sure that the offer is out there to students from a very early stage to be working with us as researchers, to see that this is not something that is kind of we're in an ivory tower, we're engaging with people, but also about how we get out there, engage with our clinical colleagues as well, and make sure that we are capacity building amongst our clinical colleagues and supporting them, for example, for pre-doctoral fellowships and things like that. So I think we need to be out there and be visible to our colleagues and be supportive to our colleagues as much as we possibly can.
Okay, thanks so much, Lynn. I'm going to have to call it a day on the webinar. I'd love to hear from the other speakers, but we simply don't have time. I thanks very much to the speakers, to Louise, Keithlin and Catherine for sharing their insights. Thanks very much to Mark Radford and to Ruth May for joining us and for supporting research. You'll find a link shortly in the chat, which will help us with, it's an evaluation, it'll help us with planning future events. In fact, we used the results of the last evaluation to feed into this event. If you could just spend a couple of minutes, that'd be great. And also use the survey to make suggestions for other topics, other ideas, other events that we might run. The NHS England is working on ways of getting the wide nursing community together like this, academia and practice, to hear about research, to help guide research, to help to get positive results into practice. And also colleagues are also working on a strategic plan for research, and there'll be a series of consultation events to help guide the implementation of that strategic plan. So please engage with that. I hope you found the event interesting and as informative as I did. And I hope that you leave the event with a sense of pride in our wonderful profession, a curiosity to get engaged and involved in research in nursing. So on behalf of the School of Human and Health Sciences at Huddersfield and on behalf of NHS England, I'd like to thank you for coming along today, and I hope to see you again soon. Take care, thank you, and have a nice afternoon.